My name is Mohammed Zaman. I'm a professor of biomedical engineering. And I'll talk about access to health among refugees. Some of our work has focused on understanding the barriers to accessing health and improving that. Some of our recent work has looked at refugees in South Sudan, internally displaced communities in Yemen, and stateless communities, including the Bengali population in Pakistan. But here I'll focus largely on refugees and internally displaced people. Next slide, please. So there are three main dimensions in which I want to talk about. On the top left is sort of just a picture of discovery of specific genes that may be triggered in relations to antimicrobial resistance. So antimicrobial resistance continues to be a major challenge among refugees because of the unique challenges that they face. That includes exposure to conflict and poor environment, sanitation, living in complex and cramped spaces, and in general, poor access to medicines. And historically, very little has been done in understanding the challenges in refugee communities. At the bottom, you see sort of a picture of medicines that are available in a camp in northern Uganda, but also technologies that we have developed in improving the quality of medicine. So not only are we interested in understanding what are some of the genes, the mechanistic side, but also developing technologies that can improve the quality of medicines and detect substandard and counterfeit medicines. On the right-hand side is some of our recent work, and here I'm just illustrating an example of the crisis in Yemen, the reason being it was also in the news yesterday with Yemen sort of not getting nearly half of the limited aid that they were asking for, and it's going to make the challenges even more acute there. So there, our work has focused largely on broader policy questions using tools of engineering, system analysis, and mathematical modeling in improving access to quality of medicine, to quality medicines, access to nutrition services, and access to life-saving commodities, particularly understanding the seasonality of malnutrition and improving sort of the work on the ground that is done by UNICEF and other agencies. Next slide, please. So we have developed these new models where we are able to analyze, for example, different states in which the children are as they move from healthy to sick to acutely sick and back, and in some cases, unfortunately, diseased, and where exactly are the resources available and where are they needed in an effort to improve sort of access of services on the ground. Next slide, please. Overall, our question remains the same as we have seen in many other places. These communities are vulnerable, they're marginalized, they're stigmatized, they're sort of really under an onset of climate change and many other challenges. And the question we are interested in asking is, can tools of engineering and basic science improve the access to medicines, improve quality of medicines, improve the relationship with health services, and above all, next slide, please, improve trust? This requires us to work across the disciplinary boundaries, not just in engineering and sciences, but in public health, social sciences, as well as communities on the ground. One of the things that we have learned, it is not often the technology or a particular medicine that makes a decision on what people choose. It is often the trust. And our goal here is to improve the trust in the system and trust with healthcare services.